Welcome everyone. My name is Blake and I will be your moderator. I'm excited to welcome Dr. Ian Shuman as our speaker tonight, as he will review proven strategies to address common elements of the more challenging indirect restoration cases. Before we get started, I would like to take a moment to go over some housekeeping. If you have a question, please type it in the box labeled "Have a Question." This webinar is sponsored by DMG. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand. Dr. Shuman, welcome and thank you for being with us tonight. I will pass it over to you now.
Hi, my name is Dr. Ian Shuman, and I'm going to discuss with you today a variety of things regarding fixed restorative. Things like fast impressions, long-lasting provisionals, some of the more complex cases that we deal with when it comes to fixed. The course is designed to provide dentists and teams with the steps needed to care for patients' indirect restorative needs. Materials, techniques, and tips will be discussed. And we'll go over everything as far as that goes. So let's review the steps from prep to provisional. So we have the pre-prep impression for provisionals. And what the pre-prep impression means is that we're taking an impression prior to preparing the tooth or teeth involved. And that's important because we want to have something stable and ready that mimics the original teeth prior to working on them. Then we're going to talk about the core buildup and what's called the ferrule. Preparation, which is the enamel peel and enamel peel technique and margin creation. And that'll be followed by some final impressions. And then one of my favorite topics is the long-term fixed with Bisacryl composite, making provisionals, whether they're crowns or bridges. And that's really that's an exciting kind of area there. So we're going to go through that too. Materials, there's lots of different materials I use. This course is sponsored by DMG and brought to you by Henry Schein. However, there's a lot of other materials beside the DMG company that I'm going to discuss with you and review, and really some exciting stuff. Lots of new materials, and I think you'll get a lot out of that. So let's talk about dental isolation first. I think that's important. As far as dental isolation goes, you know, there's been reports of patients aspirating different materials, things like parts and pieces of implants, as well as other things. So what we want to do is we want to really isolate the area if we can, and there's a couple ways to do it. Obviously, rubber damming is one, and that allows for moisture control, airway protection, and then you can also discuss the doctor comfort, because beside the patient comfort, doctor comfort is important as well. And it's important to do this because, you know, you get increased efficiency and productivity. It allows your assistant to multitask. It shortens the procedure times. And in these, with these materials, these suction tips, they allow for autoclavable. The mouthpieces are autoclavable. It provides for two-quadrant dentistry. It improves your visibility. It installs in no time at all. And there's a portable kit that allows you to move it from room to room. Long-term chairside fabricated crowns and bridges now offer clinical possibilities that were previously unavailable. And we'll go into that as well, as far as what does it mean to have a long-term chairside fabricated crown and bridge. Because, you know, a lot of times we'll wind up extracting teeth and replacing that with bridge work. And during the healing phase, which can take up to about anywhere from 4 to 6 months, we want to make a provisional that will be long-lasting. And you can do this chairside. It's really very simple, and that'll be something we'll go over at the very end. So stay tuned. So while waiting for local anesthesia to take effect, it's important to get an impression to fabricate your provisional. And the best material is polyvinyl siloxane. It's accurate, and the impressions can be poured multiple times. You can use the impression multiple times to fabricate your provisionals. Now, let's talk about local anesthesia. My local anesthesia of choice is Zorcaine. There were studies and issues before with the inferior alveolar nerve and paresthesia, or giving the Zorcaine in the palatal area and winding up with necrosis, but those are all anecdotal. And according to today's current thinking, that is not an issue. Those are no issues. Those aren't a problem. So why use traditional impression material when digital is now available? So according to the Journal of Inside Dental Assisting, Sirona is seeing 2 to 2.5% yearly growth of digital. Augins estimates that 16% of US dentists are using digital impressions. Of those, 14% use digital impressions bundled with milling, and 2% use standalone chairside systems and send images to the lab for fabrication of models and restoration. So it seems as if we are winding up with the majority of dentists still using direct impressions, and that's what I use in my practice. And so far so good. It's always been a good standby. I never had a problem. Plus, you have to have a preoperative impression even with digital. You have to have the preoperative impression even with digital because there's no way to fabricate a provisional using the digital unless you sent that to your laboratory and had them fabricate it. But there's nothing like direct fabrication of the provisional bridge or crown. So final impressions, we have something called the H&H technique, and I want to share this with you. This is a little bit advanced, and what it involves is making an impression of the crown or the bridge or the tooth preparation using polyvinyl, very specific type of polyvinyl. And what it does is it's called the H&H technique, which stands for hydraulic and hydrophobic. And this hydraulic hydrophobic technique uses impression materials and hydraulic pressure to drive a low viscosity polyvinyl siloxane impression material deep into the sulcus to capture a perfect impression of the subgingival margin. And this is done without the use of retraction cord, although you can use retraction cord if you like. There are some drawbacks to retraction cord, one of them being the tearing of the periodontal ligament. The other one being that the liquid, the chemicals, the chemistries that are used for hemostasis are often acidic in nature, and they can wind up etching the root surfaces and giving the patient post-op sensitivity. So here we have the prep tooth prior to impressioning, and represented in blue is the base impression material. However, due to the thixotropic nature, it's not designed to fully capture fine marginal detail, which is represented in purple. So you're not going to get that fine margin when you first take the impression. And by the way, when we take these impressions, we use triple trays for the most part. You can use individual trays when it's a bridge case and you need opposing occlusion as well as opposite occlusion on the opposite part of the arch. And in order to get that nice, crisp margin, we use a light body after the heavy body. So first we take a heavy body impression after tooth preparation, and the heavy body that we want, there's something called shore hardness. And shore hardness is important because that determines the hardness of the polyvinyl. And it has to be the base material, or the heavy body has to have a certain hardness to it. and they're rated. And if you take a look here at under the banner where it says heavy, you can see we have a 68. And what you want is a shore hardness anywhere between 55 to 70. No lower, no higher. If you get it too high, the material's too stiff and it won't allow you to reseat the impression. And if it's too low, it's not going to drive the light body up into the sulcus. So we're going to add a wash, which is our light body, to the set base impression. And under occlusal force, typically using a triple tray, the wash material is hydraulically forced into the marginal areas. And by being hydrophobic, it displaces the fluids, the crevicular fluids, allowing the wash to capture the margins and the sulcus. Now, when I use Honeygum, which is a DMG product, Honeygum is their polyvinyl. It's really a flagship product. It's great. I've been using it for well over 20 years. And it captures probably the best impression that I've ever had for my patients. And we get margins and beautiful impressions all the time using this technique, specifically this technique. So here's an example. Here's a single crown. This crown is a looks like a lower crown to me. I believe could be an upper. It's hard to tell actually, but anyway, here's the final impression in the base, and then we add the wash. Now, when you add the wash, you add the wash to the entire surface. Just don't add it to the prepped area itself, because that'll offset the impression and create distortion for the adjacent teeth. And trust me, the final wash or the wash will express itself out into unnecessary areas. So it won't be an issue as far as having too much wash material, because the heavy body will express it where it doesn't need to be. And you can see here's the final impression, and we have some nice crisp marginal detail, and gives us a really great impression. Here's an example of a bridge. Here's teeth numbers 3 and 6 that are prepped for full coverage 4-unit bridge, and the final impression is made with the base material, with the heavy body. The excess material on the flange was trimmed with a lab blade. So that allows the impression to be reseated once you've captured this initial impression. And then you inject your light body all the way around to all the teeth. And since normally we use this technique with a triple tray with the patient biting down, there's nothing quite as strong as a nice occlusal force. So we'll have the patient bite down on cotton rolls to drive that tray up into the and allow the material to capture the detail in the sulcus. So we have them bite on 2 cotton rolls per side. It takes about 2.5 minutes. We don't have many problems with jaw fatigue. And one of the questions that I'm always asked is, do I drill holes in the side, or creating vents to allow the polyvinyl to escape? And the answer is no, because that would negate the whole idea of this technique. We want to drive the material up into the sulcus and not allow it any escape area at all. So don't drill any holes and don't create any vents. You don't need to do that. Here's the final impression. You can see we have some really nice detail. Pay attention to the captured sulcus and the margins of the prepped teeth. The technique was described by Hughes and Kaplowitz several times. You can see we have the Journal of the American Dental Association, JADA, where it was published in 2003. The technique was published in Dentistry Today in 1998. Again in JADA in 1997. and then further back in JATA in 1996. So this gives you should give you a solid understanding if you ever want to look those studies up, look those articles up to see the technique in further detail and as to how it works and why it works. Here's an example of an impression of an anterior case using the H&H technique. You can see we have nice margins. We've prepped, used the laser around the sulcus to give us a little more room. That tissue is very, very tough as far as its adhesion to the tooth. So just a small amount of troughing with a laser usually will do the trick. Despite the bleeding tissue, the impression will capture the details with accuracy. So we don't worry too much about bleeding. As long as it's not actively oozing, it's usually not a problem. And in my practice, the technique is used for nearly all manners of impressions, including edentulous cases, as well as orthodontic aligner systems. So when you're doing your Invisalign cases and other types of similar types of product, what we'll do is take an initial impression, remove or trim away the material that's up in the vestibule so it reseats properly, and then just squirt our light body and reseat it. And that's basically it. It gives us a nice, clean, crisp impression. One of the things that drives me crazy, and I'm sure doesn't make you happy, is when the laboratory calls you up and says, "We need another impression, doctor." It just kind of puts a damper in the day. So doing it this way, you'll really capture some nice, beautiful details of the teeth, of the preps, of the margins. Now, I want to talk to you about the core, and the core prep has two primary requirements. One is custal coverage, and two is something called the ferrule. So I need coverage. Well, in cases where you have treated teeth, even not.
Hey, Dr. Shuman, can you hear us?
Coverage is reinforcement of the tooth.
Dr. Shuman?
The ferrule is at the margin. And what a ferrule is a ring or cap, typically a metal one, that strengthens the end of a handle or stick or tube and prevents it from splitting. So that's why pencils have these metal ferrules around them in order to prevent the wood from splitting, and it gives it another place for the eraser. And our crowns very much function the same way. The crowns wind up at the margin with a ferrule in order to get beyond the core material and hug the actual natural tooth structure. We don't ever want to put our crown against just the core material, because that'll result in fracture and failure.
Hey, doctor, it's Corinne. Can we go back just a few slides? Because it for some reason, the sound started breaking up and we couldn't hear you once you started talking about 1 and 2.
Here?
The 2 primary requirements. Yeah, I believe it was here.
Okay.
Yes, thank you. Sorry about that.
No problem. Just say when.
Good.
So the core prep has 2 primary requirements. One of them is cuspal coverage, and the other is the ferrule. So it's important to have cuspal coverage because in cases where you have endodontically treated maxillary teeth or molars or mandibular teeth, Just when they're just restored with a bonded composite restoration, that's often not enough to reinforce the tooth. So cuspal coverage is really designed to prevent fracture. And the ferrule is designed in order to have the crown end on healthy tooth structure. The ferrule is a ring or a cap, typically a metal one, that strengthens the end of a handle, a stick, or a tube and prevents it from splitting. That's why pencils have these metal ferrules around them in order to prevent the wood from splitting on one end and allowing the other end to have an eraser, but that's not the purpose. The purpose is to keep the wood from splitting. And the crown acts in the same way as a ferrule as long as you have it end on healthy tooth structure. We don't want to end the crown on core material. So the importance of a ferrule, the ferrule provides bracing or a casing action to protect the integrity of the root. You can see when you just have it rely on the core material itself, it'll wind up fracturing, especially with post and core cases, and the roots fracture, and then you're down a tooth. So we wind up having the crown end on healthy tooth structure, and that is what is considered a healthy ferrule and will prevent the tooth from fracturing. Crowns whose margins encompass a ferrule alter the distribution of forces. And these restorations have a subgingival collar that acts by a hugging action and prevents the vertical fracture of the tooth. To be effective, the margin of that ferrule has to be at least 1.5 to 2 millimeters, has to involve 1.5 to 2 millimeters of healthy tooth structure. That provides for the best ferrule effect when you are preparing your teeth. In a study in the Journal of Prosthetic Dentistry in 1990, Sorensen and Engelman said that the study was they did a study that evaluated the fracture resistance of pulpless teeth with various ferrule designs and amounts of coronal tooth structure. And they found that 1 millimeter of coronal tooth structure above the crown margin substantially increased the fracture resistance of endodontically treated teeth. So, something to keep in mind next time you're prepping your endodontically treated teeth. How do I prep a crown with an adequate ferrule? How do I do it in my practice? I use something called a pin diamond. These are diamonds that are available. I get mine from Comet, K-O-M-E-T, the burr company, and they manufacture these pin diamonds. So the way it works is the pin diamond acts as, or the guide pin acts as a horizontal distance keeper. For circular material reduction, the guide pin guarantees controlled preparation with an even cutting depth. And this way, a uniform preparation is created, avoiding the gutter effect. You don't want to create a gutter at your margin. We'd much prefer to have a nice, smooth, chamfer-like transition in the ferrule area. It also allows for controlled preparation of a defined crown margin. The guide pin is a vertical distance keeper as well. During the preparation of a subgingival margin, the 0.5 millimeter long guide pin assures that you have a predefined distance to the periodontium, and that is kept in check. We don't want to go too far or we'll violate our biologic width, and that's a no-no. So that way, damage to the biologic width is pretty much avoided. And so we create a nice margin at our ferrule area. The effect of a crown ferrule on the fracture resistance of endodontically treated teeth restored with prefabricated posts. In the Journal of Prosthetic Dentistry, JPD, in 2006, Pereira said that root fracture is one of the most serious complications following the restoration of endodontically treated teeth. In his study, he did a comparison of the fracture strengths using posts and cores and variable quantities of coronal dentin located apical to core foundations with corresponding ferrule designs incorporated into cast restorations. His conclusion was that an increased amount of coronal dentin significantly increases the fracture resistance of endodontically treated teeth. Now that we've discussed the ferrule and the importance of the ferrule design as well as cuspal coverage, let's talk about the composite resin core. Some advantages: the composite resin core versus using other materials as your core buildup. Composite has good compressive strength. It's easy to manipulate. You get rapid polymerization so that you're able to prep the tooth almost within minutes of having cured your core material. It provides for nice dentin bonding. Some of the disadvantages of it: there is polymerization shrinkage. There is an issue of poor dimensional stability. And today, these disadvantages have been eliminated with the use of universal nanocomposites. Very often that we'll see core material nowadays, especially dual cure. That's the one that I'd recommend. I don't recommend a light cure core material only. You need a dual cure in order to properly have it cured at depths where your light may not reach. Now, as far as rapid crown preparation goes, my preferred method for it uses burrs from a company called Spring Dental. Spring manufactures these diamonds, gives you rapid preparation. They are aggressive diamonds, which I like because the more aggressive, the faster the prep. These diamonds are electroplated so that the diamonds are actually the diamond particles are electroplated to the burr, which allows them to stay on longer. They're not glued on, they're not sintered, they're actually electroplated. Seems that hybrid composite appears to be the best material for the core buildup. So prepared core buildups in a hybrid composite material provide the highest fracture resistance, according to Burke in the Journal of Operative Dentistry. Now, there are a variety of matrix systems that you can use to build up your core material. This is a product from Garrison Dental called the Real Matrix. It's a matrix system with instruments and matrices for every posterior procedure. So I use these primarily, obviously, for posterior teeth. When I'm doing anteriors, that's usually freehand building of the core. In this case, with these Real Matrix systems, the reels pop into this handle, and retracting the grippers will lock the reel in place. So here's an example of that. They make them in metal. They also make them in plastic. And this one on the lower is the one made of plastic. And what we do is we place it circumferentially around the tooth. You can use a wedge that helps to keep it nice and tight in place and prevents the core material from oozing out over into the sulcus. So here's a case where the loss of tooth structure had previous amalgams. You can tell because there's that amalgam staining, that brown grayish stain, and there was recurrent caries. So after the initial gross preparation, we place this matrix band in place, and then we do our core buildup. In this case, we're using a product called Luxacor Z from DMG. The Luxacor Z is a dual cure material, core material, and I find that it cuts like natural dentin, which is what you want. You don't want it soft so that it ditches or gouges when you're prepping. You want it to have that same kind of feedback and damage resistance And in this case, we did a pocket measurement, and there was no violation of the biologic width, so we could carry on with our prep design. When you do preparation, there's something called the enamel peel technique. And what that does is it actually allows you to strip away the enamel in one quick, fast motion using carbide burrs. Here's a case where we did that with this molar. You can see the tooth has some problems here. The fracture defect was rebuilt with orthodontic wax just for making the pre-preparation impression of the provisional crown. It's not a restoration. It's just a quick temporary way to get the tooth built back up. So when we make our initial impression, we have a nice fully intact tooth to use as our guide for our provisional. Here, the bulk of the restoration, a bulk of reduction is performed with a carbide burr. We remove all the caries, all the restorative material. The suspected fracture at the mesiolingual did not appear to go deeper than the enamel, which is good. If it goes any deeper, then we have to assume that the tooth may not be restorable and the prognosis is guarded or poor. Peeling away the enamel and having adequate dentin circumferentially should be performed in a counterclockwise fashion, allowing the burr to work without effort. So these carbide burrs are actually designed to strip away the enamel. These are burrs available from SS White. They're called Great White burrs. And we use these for our gross reduction. Regarding tissue management and biologic width, this is just something to be aware of. Your sulcus is usually 1 to 3 millimeters deep. The junctional epithelium runs about 1 millimeter, and then you have connective tissue attached that runs for about 1 millimeter to 2 millimeters until you hit crestal bone. So typically from the top of the sulcus down, you're looking at about an average of 5 millimeters. And we don't want to go beyond that, obviously, because then we wind up with chronic inflammation of the pocket, of the periodontium. So when you have a case where you have bleeding or you want to get beyond that area where the tooth is, you have kind of oozing going on, you can just basically put in a hemostatic drying agent, and that will very often suffice to control the chronic oozing. In this case, we're using a product called Expacil from Kerr, and it does a really great job. What we'll do is use something called a compricap and place that on the tissue, and the patient is instructed to bite down for about 2 minutes, no longer, because that can cause muscle fatigue and they can get tired. And if we're using triple trays, we don't want them to have muscle fatigue or jaw fatigue at all. But you can see on that distal area how we have a nice, clean sulcus, and that's ready for impressioning. As far as sulcus management goes, if you have a bleeder or an oozer, a simple laser, low-cost laser is always great and effective at doing the job. And that's what we'll use in our practice is the laser to do that. And here we have an impression of that tooth. And you can see once you've removed that, irritated and oozing material, you can allow the light body to penetrate down into the sulcus. Here's tooth number 18. It has a failing restoration. There's proximal caries, and the tooth has a bit of a guarded prognosis, especially when you think maybe it needs endo. So what we'll do first is get our impression for our provisional, and we use a product from DMG called Status Blue. That's what this is called. It's it's kind of a medium body, very flexible polyvinyl siloxane, and I like it because we can use it over and over again if we need to. If the patient loses the temporary, if the temporary breaks, we can easily just fit them with a new one, and we just keep this in their lab box during the time that the laboratory is fabricating their final crown. If a tooth has a guarded prognosis, it's best to perform a procedure that will attempt to solve the problem chairside. And in this case, because we weren't sure if it needed endodontic therapy and if it was fractured, we want to put a long-term provisional crown on this tooth because, number one, if you don't need it at the time of the prep, the endo may be a potential in the future, and then you don't have to destroy a good, healthy lab-fabricated crown in order for the root canal to be performed. And after prepping and temping, the tooth eventually becomes non-restorable, and you haven't invested a lot of money into it, and the patient hasn't either, and it makes things a little more comfortable for the patient financially. So you can have these long-term provisional crowns on teeth without too much worry. The way to do it, here we're using a bisacryl composite called Luxatemp from DMG, and we fill the preparation impression with the bisacryl. We fill it to the margin. That way we avoid insufficient material and thin spots. And after 2 minutes, the material is set. It's ready for trimming and ready for cementation after that. I usually trim these with a diamond burr and then finish it up with a polishing burr. So we have a nice smooth margin. Now, wouldn't it be great if we could create a long-term chairside fabricated bridge intraorally prior to extraction of the pontic tooth? So we can do that, and I'll show you how. Here's a case where we have a tooth with a good 12, 13 millimeter periodontal defect, which indicates that there's a fracture in the isthmus of this tooth. So the tooth has to come out, we know that, but what we don't want to do is we don't want to take the tooth out and then start fabricating our provisional, because that will cause contaminants to get into the extraction socket. So what we'll do is we'll take a primary impression. In this case, this was before Status Blue came on the market. This is many years ago. So we have another type of material, also a medium body from Parkel, and we use that. And then lower posterior quad prior to treatment. And what we'll do is we'll take the crown off the most distal molar and prep the premolar. And the tooth to be extracted is prepped to create a pontic space. So we'll just remove the crown and then using a football diamond kind of ditch out that area where the pontic should be. Then it's just a matter of making your provisional bridge and allowing it to bench set for a few minutes in order for it to fully polymerize and shrink. And this is what the untouched provisional looks like after removal from the polyvinyl. It looks almost perfect in that regard as far as the original teeth. We can use Luxacrown for a long-term provisional. Luxacrown has a glass filler material and a matrix of multifunctional methacrylates. It has catalyst stabilizers and additives. It does not contain any methyl methacrylate, and the filler content is kind of large, which is why it's able to stick around for so long. Some studies have found that the Luxacrown can be used on a patient for up to 5 years. So it's something to keep in mind and something to keep in your arsenal in case you need long-term provisionals. Prior to extraction of the molar roots, the provisional is tried in, and any adjustments, additions, or changes can be made at this time. Doing it this way avoids introducing foreign bodies into the extraction socket. And your final step would be to remove the provisional, extract the molar roots, and cement your temporary bridge, your provisional bridge. How about core buildups and fiber reinforced provisionals? So here's a case where we have a tooth that has failed the molar. It's had endodontics twice, and there's now a fracture in the mesiobuccal root. You can see that with the little abscess forming at the gingiva. And what we've done is we've removed the crowns from the premolars, and the molar tooth will be prepped as well. And we'll remove the crown and ditch it out to create a pontic space. In this case, as far as core buildup, we're using Luxacore Z, once again, from DMG. And what we'll do is we'll reinforce that bridge with some fiber reinforcement. Now, as an industry, in dentistry, we're at the leading edge of composite resin and fiber reinforcement technology. The materials we use are highly sophisticated. So bear that in mind. Why does composite resin need to be reinforced? Well, when you used to join teeth together, composite resin materials, which are chemically brittle by nature, are susceptible to fracture and are not durable as a standalone material. When you're supporting pontics, stabilizing mobile teeth, cracks within the connector area lead to outright fracture, something that is known as catastrophic failure. So splinting teeth creates challenges when the restoration must function over longer periods of time, as in our provisional bridge. So how can dentists minimize these clinical failures and still use conservative techniques for tooth stabilization with adhesive composites? And how can we improve the durability of long-term provisional bridges? So the solution: over the past 20 years, a new class of materials designed for reinforcing dental resins has been introduced. These products are fiber reinforcing ropes, braids, ribbons, mesh, and bundled fibers. Clinicians and researchers have investigated the embedding of these fiber reinforcement materials into dental resins and found that they provided for an increase in certain physical properties and for more durable tooth stabilization. In 1983, the first attempt at reinforcing composite resin was met with failure. A study was undertaken to compare the flexural strength of unmodified and carbon fiber reinforced composite resins, and they did this without reinforcement. The findings of the study showed that the addition of carbon fibers to a dental composite resin decreased the flexural strength. So what we had to come up with was something that would actually be an addition to our composite resin. Some of the things that we used in the past: ortho wire, square and round, thin and twisted. Thin wire, twisted. We used nylon and fine stainless steel mesh, perforated steel strips, something called Ziza bars. I don't know if you're familiar with these, but that was something that was used. With wire and resin, with the clinical predictability of adhesive procedures, the use of conservative bonding techniques to splint teeth offers a useful alternative to more invasive restorative fixed prosthodontic procedures. There were reports of clinical techniques embedding wires, pins, nylon, and stainless steel mesh into restorative resins. The clinical failures occurred because these materials could not support the repeated loading stresses placed on the splint during normal and para function. When it came to wire, mesh, and resin, other techniques using this also didn't perform well. The problem with embedding metal or nylon grids into dental resin is that the materials were chemically incompatible, and the resin would break away from the mesh or the wire. So in 1991, a new method for long-term chairside provisionals was described by Belvedere. Paul Belvedere said that in many situations there is an indication for the creation of a long-term functional chairside temporary bridge or crown utilizing a cold, light, dual cure composite material. In his case, he used dual cement, reinforced with polyethylene fibers, which is an excellent strong bridge or crown, with which an excellent strong bridge or crown will result. Fiber reinforced composite restorations offer a minimally invasive, low-cost alternative to conventional crown and bridge restorative dentistry and periodontal splinting. It offers exciting applications in the repair and strengthening of dentures, ortho retainers, and the provision of aesthetic custom-made posts and cores. Here's a case where I'm actually going to use Ribond, which is my fiber reinforcement of choice. And we take a pre-measurement, we measure it out, and make sure we have, in this case, I believe we use 2 strands. Here's 1 strand on the lower image. And we're going to use, in this case, we use Luxatemp from DMG. It's a bisacryl composite, and remember that the Ribond will be chemically compatible with the Luxatemp. Here we take 2 fibers, and it's important to use 2 because that creates what's called lamination, and lamination provides incredible strength to your bridge work. So here we have the bridge that was inserted into the patient's, we have the impression inserted in the patient's mouth, and the ribbon basically dissolves, or it doesn't dissolve, but it blends in to the bisacryl material very nicely, so you can't even tell that it's there. So it's hiding in the inside, but it's just, and it's doing its job without coming out, showing itself. And then it's just a simple matter of trimming the bridge up. In a case where you have holes, because sometimes there are perforations, little blebs and things that occur in the provisional, just use flowable composite to repair that. That's another technique tip that will help. Luxatemp does not stick to itself after it's cured, so you have to use a flowable composite. And here's the final product after fabrication. Luxacrown, how does it fit in your practice? Well, basically, it's really ideal for these long-term provisionals, is what I would tell you. If you have long-term cases, patients with bruxism, cases that are challenging as far as vertical dimension, really a nice material to use. And if we want to correct occlusion intraorally using Luxacrown and Ecosite, which is a bulk fill composite, we can take the bridge, the provisional bridge. This is a 4-unit Luxacrown bridge, completely lacking occlusion. It was what we made from the initial impression. And obviously there's been issues with the patient bruxing. And so what we'll do is we'll take the bisacryl without removing the air inhibition layer and add a bulk fill to the occlusal aspect of the provisional. Prior to curing, we put a celluloid strip in, and we have the patient bite down. Now they're in maximum intercuspation, and we light cure that while the patient is biting. And then we can add additional bulk fill to the facial aspects and finish our provisional bridge. Here's the before, here's the after, and you can see now we have the patient in proper occlusion and proper facial contour. Here the patient presented with a broken provisional bridge. So we made a stone model, we took an impression, made a stone model, put the broken segment back onto the model, and then from that we were able to take an impression of the case using status blue, and now we're ready to go ahead and prep and fabricate a new provisional bridge. Here we use the long-term provisional using Luxacrown. If you have any questions, you can, you're welcome to ask them. And this concludes today's lecture. Thank you for your attention.
Thank you so much, Dr. Shuman, for joining us tonight. We did record tonight's webinar and we'll email the recording out sometime in the next week. We would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you for joining us, and we look forward to seeing you on future webinars.